الوضع يصل وسط.
Specific country. So I want we look at the capacity to deal with the pandemic in Africa in general, and in particularly focus on our region in East Africa. The second question is basically if we want to reflect and think what could happen by the next couple of months in this part of the world, and sort of our people, we have to have reliable numbers to predict things, to see how we can, in how to say in the terminology, to flatten the curve. But if we don't have numbers and reliable numbers and reliable data, knowing the capacity of testing of our countries, we want to have that kind of information if we can get from our speakers and reflect on in the case that we don't have that numbers, how we can predict things. The third and the last question is how crucial is the inter African country collaboration in this moment. In this crucial moment, at least if we focus on our region, how regional capacity and collaboration, at least on the healthcare issue, is important. So this could be a message to our policymakers to understand why it's so important to have this open collaboration within the region and then within the bloc of the countries that close to each other, and then in the African continental. So I would say I would limit myself just to frame in our discussion in those three areas, and of course what our presenters will share with us will guide the rest of the discussion. I want to just for technical reason remind that Dr. Abdurrahman and Dr. Sahai will be having 5 minutes, which will be focusing on what Dr. Ahmed and Professor Sanet has said, and so to facilitate the discussion for the rest of the people. I know that the issue is important, so we'll be having other sessions related to as a continuation of this discussion. One last thing is for our attendees, I see that many people are attending on Zoom, but also we are on Facebook Live, so your questions will be collected by a group dedicated on the chat or in the comments according to the Facebook or Zoom where you are asking. So please raise your question starting from now, so the team can collect in time and share with us, so our presenters can respond. So please start now asking your questions through comments on Facebook or through chat in Zoom. Having said that, I would hand over the mic from distance to Dr. Ahmed Hussein Isa. Thank you. Welcome, Dr. Ahmed. I see the mic is closed for Dr. Ahmed.
Yeah, okay, so I'm back on, I hope. Is that okay now?
Yeah.
Okay, yeah, thank you, Shama, for setting the stage. I do appreciate this forum. I think it's a very important forum for us to engage in this period. When the pandemic started in China and then went through Europe, the predictions for Africa were quite dire. We were facing, as all the scientists and all the epidemiologists were at that time predicting, we were facing a storm in Africa. Africa did not have the right tools to withstand this virus. Other countries that had more robust healthcare systems, like northern China, France, Italy, the US were crumbling at the feet of this pandemic. So we were talking about a situation where once it reached Africa, it will be devastating. Our healthcare systems are not what they should be. We were talking about the number of ventilators per million people in Africa that were really minuscule. So we were really looking at a problem that was going to be extremely difficult for us in Africa, and especially in particular for some countries in the Horn of Africa. Those predictions, thankfully, have not been borne out. We are now in a situation where the numbers in Africa are quite low. We can talk about the reasons why this is. There may be many reasons for this. Because of the bad predictions that we had early on, and the fact that we didn't see those predictions come through, my fear is that we are going to be lulled into a state of complacency. We will stand down. And if we do that, we can really, in my opinion, get into trouble later on. If you look at the numbers that we have now in the Horn of Africa, of course, there are 6.5 million people around the world that are infected by this virus. We have almost 500,000 people who have lost their life. But in Africa, the numbers are quite low. In our region, we have maybe 7 people. Mortality is quite low in Ethiopia. The number of positive cases is quite low, less than 1,500. Kenya, just about 2,000 people have been confirmed to be infected with COVID, with SARS-CoV-2. One death yesterday, and we have tested positive only about 332 cases as of today. In Somalia proper, it's only about 2,000 people that have been tested positive. Djibouti, which is testing much more robustly and much more aggressively, has about 4,000 people that are now confirmed positive. So those numbers are quite low, but it may be we're not testing enough. Certainly that's the case, because we're not testing enough, except the country of Djibouti. All the other countries, Somaliland, Somalia, Ethiopia, Kenya, we haven't really tested enough at all. Djibouti has tested more than 31,000 people as of today, and that's high for even international standards. And if you look at the case in Djibouti, the recovery rates, the mortality, the recovery rates are certainly quite favorable and quite comparable to what we have in other countries. The mortality is not. Mortality is a bit high in Djibouti, but that could be just an anomaly of statistics that sometimes happens. But what my point that I would like to do, take from here is, I don't really want to discuss the reasons why some of these dire predictions we all know those. We have the young population, certainly. The virus came in late into Africa. Africa is still isolated from the rest of the world commercially. Tourist-wise, we don't get the number of people that are coming from outside into Africa like we're getting in other countries. So the virus came late. And also the timing of the virus arrival in Africa was fortunate. Because it came in the more warmer months of spring, and now we're going to summer. And there's good indication that warmer temperatures may moderate the transmission of this virus. So we were lucky in that sense as well. But we need to go back to history. This virus is new. This SARS-CoV-2 is quite new. We haven't seen it before. We do not know how it's going to behave. We do not know whether it's going to be serious. But if we take an example, a page for other pandemics that we have seen of respiratory disease, we have seen these viruses come, and if we go back, and this is the reason that I think we should talk about the Spanish flu of 1918, 1919, 1920. We should speak about that because you look at that pandemic as well. It was Africa late. That pandemic has two waves. The first wave did not affect sub-Saharan Africa at all, or it affected it minimally. But then, as time went on, that pandemic started in exactly the same way. Winter, spring in the northern temperate countries, and it didn't reach us until the summer. When it reached Africa, sub-Saharan Africa in the summer, it didn't affect us that much. But the second wave came around September, October, and that was devastating. In Addis, in Ethiopia, if you go back to history, if you read some of the historians, the history books at that time, that pandemic affected Ethiopia quite devastatingly. It affected every echelon of the community, including the higher echelons, the clergy, the leaders of Ethiopia. In Addis Ababa, people were talking about, although they thought it was a typhoid issue, they were talking about bodies lying in the streets. The numbers, we don't really have good accounting of the numbers, but estimates go from 5,000 to 10,000 people dying in Addis Ababa at that time. And Addis Ababa at the time was a very small town. And then in Kenya, in Nairobi, it came through Mombasa with the return of the soldiers that were coming from the Second World War, fighting with the British. They came through Mombasa, and Nairobi was devastated. In Somaliland, same thing happened. It came through Berbera, and in some cases, we had fatalities of 7%. And in some cases, in other cases, we had some fatalities of 25%. In Djibouti, the same issue happened. It came through the port of Djibouti, and it affected that small population quite remarkably. So my point really is that we really, even if you do get through this first phase, the way it seems we're going through now in the summer months, we need to get ready. We shouldn't really have, we shouldn't tempt our luck. We should be getting ready for the winter months because there's the likelihood that this virus will come back, will be with us for a number of years is there until we get a vaccine, of course. But the likelihood that it will come in the colder months of the winter coming up, it will percolate as I think it will percolate in our community, going through community transmission in a sort of a stable way. Although there's always a chance because these viruses with the reproduction rate greater than 2 have a tendency to go through exponential growth very quickly without notice. So it could really explode even now. But even if it doesn't, what we need to do is to really think about not bending a curve, as everybody's talking about, but getting ahead of the curve so that we don't really have a curve at all. So we start preparing for it now, getting the right data, as Chana said. And I see the numbers that we could use now. We could use the situation in Djibouti, for example, with this robust, aggressive testing, but we cannot tell from just the numbers that are put up what those numbers mean. Whether those numbers were a prevalence, whether we can glean prevalence data from what Djibouti is doing, because Djibouti has tested already 31,000 people. So we can get good ideas. And this is perhaps where I think Dr. Fasiha and our colleagues in Ethiopia can talk about, because the African CDC is there. And I think this is where the African CDC, for example, can come through. When I was back in Baltimore 30 years ago at the Johns Hopkins Medical School and the School of Public Health, the CDC, the US CDC was the star. Everybody looked to the CDC in Atlanta, but it's no longer the same. It's not the same CDC that I knew 30 years ago. But we don't have to rely on the CDC on that CDC anymore. We now have the African CDC. We should demand that the African CDC give us good analytical data, looking at countries like Djibouti, looking at countries like South Africa that are doing good testing, and so we can get an idea of what's going on. So I know Dr. Fasiha has to leave because she has another engagement, so I'll stop there. I won't, although I think I promised yesterday that I'll be short, but I did not succeed, unfortunately. So I will stop here and let the rest of the panel take over.
Thank you, Dr. Ahmed. And I think for the sake of the time, I would ask Professor Sania to start immediately in her speech.
Absolutely. Thank you very much, Dr. Jaman. I'm very grateful to you, to Tursit, to the Hargeysa Cultural Centre, as well as to my esteemed colleagues for coming together to address this very timely issue. We all know that we are seeing very challenging times, ones like we've never seen before, at least in our lifetime. Even nations like the US and European nations that have a much advanced healthcare system have been struggling with this. So although it's early in Africa, we absolutely worry about the potential for COVID to overwhelm our system. Because Dr. Issa spent time really focusing on the region, maybe I can lift up and give a little bit of a global perspective. I mean, he did review that globally right now we have very large number of cases. We have seen over 6 million COVID infection with 380,000 deaths. But if you come to the continent of Africa alone, we have about, according to Africa CDC, as of yesterday, we have about 158,000 infections and 4,500 cases. So although we are in the early phase that we are concerned that cases are rising, but when you lift up and look, give yourself a perspective, with a population of 1.2 million people, infection of 158,000 still very, very, very small. Compared to the global infection, we are about 1.2% of the global infection. But while there have been far fewer cases on the continent and in most low and middle income countries in general, we're now beginning to see the shift. I mean, Dr. Issa talked a little bit about the seasonality. We're not 100% sure, but the fact that the COVID-19 epidemic peaked in the US during the winter, and now as the temperature cools, we are seeing a peak in Latin America, that are getting kind of entering the colder season, seem to suggest there may be some seasonality. The fact that we are early is a good thing. It means it gives us time to prepare. We know we have very weak health systems that need a lot of capacity building. The key issue for us right now for the continent is the low testing capacity. We are struggling with community rumors and misunderstanding. There is weak disease surveillance, high workload of our health system. So I think we have a lot of things to do, and I know some have been suggested around what can we do for learning from each other within the region, within the continent. What can Africa CDC do? And I think a very good place to start maybe around the work Africa CDC is doing under the leadership of John Kengasong. As you know, the continental leaders have come together and have launched, and in fact by working through all the health ministers, they've launched a continental strategy to tackle the COVID pandemic, and Africa CDC is put in the lead. International organizations like the World Health Organizations are heavily involved, but Africa CDC just launched what they call PACT, P-A-C-T, Partnership to Accelerate COVID Testing. Basically, this is to help African countries increase their testing capacity, increase their tracking, tracing, and treating, as well as really mobilizing foot soldiers to partner with community health workers and really help with contact tracing. You hear a lot of conversation taking place around our inability to test. That is a big limitation, but equally limiting is what happens once people are tested and once you separate the positives from the negative, right? Because the whole strategy to boxing COVID is to identifying the people who are positive, isolating them, treating them, and then ensuring we contact trace the people they come in contact with. That's sort of how you go through the cycle and box the disease. So Africa CDC is working with the ambition of creating about 1 million foot soldiers to do this contact tracing. They've also done, I think they're getting ready to make announcements in the near future, but they're also working around creating a continental platform for purchasing commodities. One of the biggest challenge Africa has right now is we just don't have the economy of scale. When you look at each country trying to go into a global market and negotiate and buy commodities, we are in an extreme disadvantage. We've heard stories of Europe and US, outbidding everyone and taking, most of the PPEs and the ventilators and the testing kits. In fact, to a point where they're even hijacking airplanes that are passing through the cities. And as a result, Ethiopian Airlines has emerged as the preferred carrier now to distributing COVID supplies. But what we have now seen, which I'm very, very encouraged about, is having a continental strategy, having a regional strategy, sort of bringing countries together, learning from each other. What are the best practices? If you look at Africa right now, about 5 countries are reporting 75% of the cases for the continent. So as countries' testing capacities increase, of course, we're going to see more cases, but we're also having other emerging issues like cross-border transmission, especially in Eastern African countries. As we ease lockdowns, we're going to we have to find a way to figure out, sort of how do we tackle the public health challenges without shutting down our economy. But we're seeing, for example, in countries between Uganda, Tanzania, Rwanda, there have been a lot of reports of cross-border transmission. So we need to focus and tackle that. But I cannot, emphasize enough how we need to come together as a continent to get supplies at economy of scale, which, as I said, Africa CDC is leading, and they should be announcing soon that they're creating a platform to be able to purchase, for countries to get together. Somaliland alone would not have the ability to go out and negotiate either with Chinese manufacturers or European manufacturers to get the best prices when there is so much demand. But if we come as a continent, we can achieve that. We're also seeing right now significant shortage. A lot of, as you know, like antibody and antigen testing are not available, rapid testings are not available. So we are still relying on molecular testing PCR machine, and there's significant shortage of reagents and swabs and what have you, like supplies, which I think we can only overcome if we tackle this as a continent and not individual countries. I mean, even the more developed countries like South Africa and Egypt are struggling. So when it comes to smaller countries, when it comes to weaker economies, the only way we can achieve this is by pulling together as a continent. So if I underscore a few points as a wrap up, I think it's really important that we ensure facts of the WHO response timeline, all these things, guidelines get disseminated broadly. I do worry about misinformation a lot. We heard at the beginning, COVID does not affect Black people. Africans are not going to be affected. We hear in Ethiopia, for example, altitude having a protective effect, or even, the president of the United States making assumptions like, we Africans take a lot of hydroxychloroquine for malaria, so they should be protected. Or we're used to Ebola and chikungunya and other infections, so we're not prone. Religious leaders, I think, have a huge role to play in ensuring that accurate information goes to the communities that need them the most to protect the most vulnerable. We also hear stories that young people will not be affected. But we are now seeing, for example, if I look at my own country, of the 14 or so cases reported, a significant number are young people, right? Especially, our workforce is young, our frontline health workers are young, and if we don't have the necessary protective equipments they need, they're going to be at risk. So I think we really need to make sure that we get accurate information. And then the other, I think, big factor right now is we don't have a cure, we don't have treatment. We know hand washing is as preventive a measure as anything else we can undertake. Most of our communities live in a very tight places, intergenerational families. So the idea of social distancing or physical distancing is not a reality for most of us. So how do we ensure masks? How do we ensure we don't cripple, livelihoods, but then we ensure that we are protected? So I think there's a lot we can do as a community. As tough as these issues are, the young age of the continent is certainly an advantage, but that doesn't mean that we don't take significant measures to protect our communities. If I say one more thing in terms of, social distancing, it's not going to work for many of our countries. Like, my home country of Ethiopia, our economies are informal. They require human interaction. Many lives in formal settlements, or like I said, they live in multi-generational houses. So what are the things we could do that are within our control? So for example, many countries in East Africa have taken measures to right now ban large religious gatherings, social gatherings like weddings, that can minimize the spread of the disease. But I think at the end of the day, the best way for us to tackle this is, as Dr. Issa said, is try and get ahead of the curve, not necessarily, flattening the curve. All the measures we're taking are to flatten the curve. When we say, wash your hands or social distance, use protective gears, those are really to slow down the infection. And until a vaccine becomes available right now, we don't have any other therapeutic measures that we can take. And in terms of vaccine, if I can add one more thing, is ensuring, vaccines right now, there are over 100 competitive vaccines that are being developed. Some have been accelerated and have gone to clinical trials, but then how do we ensure equitable access of vaccines to those countries that are not investing in research and development? So again, WHO is leading this effort to ensure that vaccine discoveries and having pooled patents, and ensuring that vaccine will be, when they become available in 12 to 18 months from now, are going to be equitably distributed. But I will make one last comment before I leave, is that when we think about this pandemic, it's affecting everyone. As we've heard earlier, right now, no one in the globe is spared. With over 188 countries, over 6 million people, it's an unprecedented global crisis that's going to require global, bold, courageous leadership. And this is not only leadership of our elected officials, but this is leadership of our healthcare providers. This is leadership of our community leaders, our religious leaders. And I think each and every one of us have a huge role to play. But having said that, there is a subset of population that are going to be affected the most, and these are women and children. If you look at the continent of Africa, the large number of our frontline healthcare providers are women. These are midwives, nurses, community health workers, and these people are leaders, but they are also frontline healthcare providers at home. They are taking care of their parents, they are taking care of their children. So I do worry about the disproportionate impact this is going to take on women and girls and children. So I think we all have to keep that in mind and do our best to protect these vulnerable communities. So I will stop here. I am very grateful for the opportunity to participate. Unfortunately, I have a pre-existing commitment that's going to require me to depart. And if you are not finished, I'll try and join before the end of the session. But if not, I look forward for many opportunities to engage in the future. And I'm enormously grateful to the Hargeysa Cultural Centre for bringing African sons and daughters of Africa to really tackle this very critical issue and create a platform to engage our communities in this conversation. So thank you very much, and I will end here.
Thank you so much, Professor Sani. I really appreciate knowing that you had commitments and then you joined us. And I'm sure we have, as Tisi was saying in the introduction, we have almost 15 upcoming events on the same subject in every Wednesday. So definitely we will have another chance to come up and to, to bring you on board on the discussion, but also the continuation after this conversation offline would be really grateful because of the region, because of people like Dr. Ahmed Hussein Isa, who is both leading and working with the committee, Somaliland National Committee for this pandemic. Will be helpful to have proper connection, see how we can go from there. So I appreciate, and we let you go. Thank you so much for joining us. And then we will have, there are specific questions for you, but we will give you offline those questions, and we will have a way to answer those questions. Thank you so much. Thank you so much. Now we are going to immediately to Dr. Suhail Hassan Ahmed, who will be the first respondent and focusing on what Dr. Ahmed Hussein Isa has said. Dr. Suhail has 5 minutes to summarize for us. And Sunny said there are a lot of questions and discussion going on, and specific question is mainly, luckily for Dr. Ahmed Hussein Isa, I would recommend that we stick on our 5 minutes each of you. So let us start with Dr. Suhail.
Good evening, and thanks to Dr. Chama and Hargeysa Cultural Centre for inviting me for this good discussion, actually, because the region and the continent and the context as well need us to talk about it. And I hope that we will do a lot of sessions like this. If I try to summarize what Dr. Ahmed have said previously, he was talking about that the disease or the pandemic has hit the continent Africa late, but we don't have the right tools to detect, to test, to trace, or to respond to the COVID-19. And that's a challenge for the continent. Also, he raised it that the cases are low now, but we don't know if it's going to be the same in the coming months, or it's going to reach or hit like the Spanish flu did, because the Spanish flu has two phases. The first phase didn't hit much in Africa, but the second wave was very aggressive and hit countries like Kenya, Ethiopia, and Somaliland, like Pareil and Djibouti as well. So we don't know if it's going to be like this or it's going to be like it's. So still we don't understand how COVID-19 will be in the continent. Again, he talked about that we need to have a good relationship with CDC, because CDC, particularly CDC in Africa, because it's for the whole continent and the region, to give us the good advices on how to trace, to contact, to do the contact tracing and all these things. With what Dr. Ahmed also said, if I come to the context, particularly to Somaliland, I can add that we have a challenge with the contact tracing, with the testing and detecting the case, and also to respond to this pandemic. We have that thing. One thing, again, we have a challenge in the equipment. Lack of oxygen is maybe we have some, but it's not that much. Ventilators we are lacking. And then that is the challenge. If we need more, if we have a more serious cases that need this admission and they are in respiratory distress, then we will need ventilators and to save lives. Again, we have training to where the healthcare workers actually, how they're going to deal with the cases and how to prevent among the cases as well. And to prevent themselves, and another maybe the test that we need to test the cases could be run out, or the machine is something happened to them. Then again, we have a supply chain problem. One thing that we cannot forget is like, because we have risk groups, we don't understand if it's going to be the same like in what's happening in the developed country like Europe and so on, because we have seen that people who died for this disease were majority, or the risk groups was aged people. Is it going to be the same with us? But we know that the continent, we have a very young population who living in Africa. So we don't know if it's going to kill young people or so on. So age is again is a problem in the context that we live in. we have as well people who living with non-communicable diseases, because people who living with non-communicable diseases are among the risk factor groups. So those who have diabetes, heart failure, hypertension, again, how have we developed a strategy to take care of them? Do we have the appropriate treatment for their diabetes, hypertension, and so on? And one last thing is, we have a lot of cases in the urban. Is it going to go to the rural communities? And if this disease goes to the rural community, how are we going to do the testing, tracing, and so on? So I will leave the floor for the others, and thank you so much.
Thank you so much, Dr. Suhair, for summarizing, and also you're adding some more points for discussion, and that's the role of the respondent, of course, to summarize quickly that the major salient points, but also to anticipate a little bit the discussion. So you grateful that you added some key issues. I know that Dr. Ahmed Hussein Isa has still something to say about his what he prepared, but I would go to Dr. Abdurrahman Mada, and just I want to take advantage that people are asking now that we are all here, and the discussion might switch to Somali language. I just want to inform that we will be having entire parallel sessions that's going in Somali language, focused on Somaliland context. But this series of Wednesday webinars are more African, broader context, so we will still continue speaking English the Wednesday sessions, while the Saturday sessions will be dedicated on Somaliland, so we'll be speaking there in Somali language. Dr. Abdurrahman Mother, thank you so much again for joining us. The floor is yours for your 15 minutes, for your 5 minutes.
Okay. Thank you, Chama and Hargeysa Cultural Centre, as well as my panelists, and mainly our audience. I would support almost all what Dr. Ahmed Hussein Isa and Dr. Sanayed said. My time is limited. I will pinpoint one point that in terms of prediction that the Western media did about potential devastation in Africa. I think that is true. I would also like to add that it is important, as long as we have the disease, in order to know the extent of our enemy, you need to know about something about the enemy itself. I am coming to what Dr. Sanayed discussed, which is a testing. And whenever we are presenting a data, epidemiologists would have a lot to say about that. We need a denominator. If you don't know the denominator, it is hard to really say what's going on. So I would take a grain of salt that our cases are exactly as reported. Testament to that would be Djibouti, which is a very small country, less than 1 million population, with that number of positive cases, which I assume it has to do with the testing. So testing is important. Another thing that I would like to point our attention is that we do have almost every African country a gene expert testing, that it is a molecular diagnosis meant for HIV and AIDS. It is there. I know around 15, close to 20 such machines are there in Somaliland alone. They can be retrofitted using a cartridge for COVID. You put a COVID cartridge. I know the cartridges are in short supply, but that's actually, I want to take that out there for policymakers to think of taking advantage of already existed machines that we have. Dr. Sanayed discussed a lot about global aspect. I would add one thing to her discussion, that we do have a small, relatively small East African community in the city that I am sitting right now. And I would support that this disease kills everyone. We are lucky it's not there in Africa yet, but I would like to take advantage of that. We know it kills. I'll give you an example. The state of Minnesota, small state, 5-6 million. The Black population is 6%. And the data from yesterday, 22% of people with COVID and 20% of death for COVID are Black community. Imagine 6% of the population, 20% of death. Of course, there are a million other factors, but I would like to be very clear that our skin, who we are, where we come from, would not protect us, at least so far, from COVID. In terms of mitigate, another thing that I would like to take this advantage to say is the mitigation is that we designed for COVID-19 are actually effective against a lot of diseases that used to kill us before COVID, during COVID, and after COVID. These are infantile mortality, lower respiratory infection for children. I think hand washing, cover your cough, these basic things should stay with us for the long run. It's my opinion that shake hands should never come back, actually. I think by just following and trying to maintain, of course, you cannot maintain social distancing for a long time, but we can modify, probably retrofit our seating in some restaurants. So I would add that to the point. The last thing that I would give you an example is that flattening the curve, it's extremely important for us. As many of you know, and my previous speaker has mentioned, we don't have that much of a big intensive care unit and ICUs in Africa. So the whole flattening curve is supposed to be avoiding small hospitals being overwhelmed. Our hospitals have already been overwhelmed before COVID. So I would emphasize that mitigation strategies that we have, I think it is the way to go. I will say one word about a saying that I like. It is a parrot from politics. They say, never let crisis go to waste. What they mean is whenever you have crisis, it will come with a resource mobilization, media, awareness. So you keep that momentum and repurpose to maintaining and refocusing and making use for other problems. In this situation, just keeping the preventive measures that we have in a modified way would be great. One example, I'll give you one example. The Japanese people are really doing well. What they didn't do strict lockdown, but what they did kind of modified little cultural norms that they included their individual behavior. They did well. Another example for if you let the people go and don't do mitigation would be South Korea. South Korea did great, we know, but they kind of relaxed and went back to life as they're supposed to be doing. And today they are reporting around 50 or 4 more new cases. I would add that intercontinental learning from each other is great. Great example for Africa, I would say, is South Africa. They do have a kind of 8 overlapping strategies, starting from identification to after the people die. So you don't have a time to discuss that, but I would direct you to look how South Africa did. Again, I will come back to the testing. So testing is important, but you don't have to wait testing to mitigate. So we know the disease, and even if COVID passes, I can argue that if we maintain 10% of current intensive mitigation is that we have, would probably make a dent on our infant mortality, maternal mortality, and it's a common sense. It is an opportunity to change our local culture so that we can fight these diseases. We need to fight because you own what you have. That's a good example. Imagine what happened to Italy. Even the European, Germany and close European is actually close their borders. When crisis comes, you have what you own. So it is time for Africa to really depend on itself and try to take advantage of this opportunity that we are still doing well. Imagine, I'll give you an example. I sent a one hand sanitizer. I wanted to send someone outside of the United States one hand sanitizer. The customer sent that back to me and told me that you can send hand sanitizers from the United States somewhere else, which means when crisis comes, you own what you own. And I will leave and happy to answer questions when they come. Thank you.
Thank you so much, Dr. Abdurrahman, and thank you for respecting also timing, because I know we have a long list of questions, and mainly since our speaker is now, Dr. Ahmed remains with us. Many of the questions are directed to him, and since he had still something to finish in his conversation, he can take advantage of while answering the direct questions. Some of the questions are also for Dr. Shahid as well as Dr. Abdurrahman, so I will come back to that. I wanted to start just to one of the questions that I can answer as organizer is from Germany, from Patrick Yamnish, who connected from Germany, who was asking why you are feeling about the winters, and he said the climate here is hot and it's not cold. But I think it's just the title is misleading if you think about winter. We wanted to see what will happen in a couple of months or 3 months of time ahead. So instead, it's not the winter by itself as a weather, but it's the timing because of knowing what could happen and when the projection as a peak, what could happen in Africa. That's why we choose the term winter and not as a weather. So it has nothing to do with the climate and with the temperature. Many questions. I wanted to also to take advantage of the time, so I want to put together some of the questions. So I would one of the questions from Mohammed Roble, who is asking if Somaliland government put in place a strategy and if it's available on some way. So if we can share with it, but I think that question Dr. Ahmed can answer. I want Dr. Ahmed to take notice for questions I put it together. So that's if the Somaliland government put already in place a strategy and if it's available in some way. Also, another good point, Dr. Mustafa Awil from Uganda, from Kampala, is asking is how we can balance and the cultural and religious issues that might hinder COVID-19 measures. I think this question is also related to what many people are asking is about if the information that people are getting is the correct one, and how we in Africa, in regional wise, Eastern Africa, and in particular in this case, Somaliland, how we can deal with giving the right information to the people. So there are many people who are asking in different ways that question. One third thing is from Alale Hussein, and it's for Dr. Ahmed. And basically, the question becomes is still on the issue of if we have context-based strategy that we have to get for Africa. It doesn't work, the global stay at home, wash your hands, which is fundamental, but it is not applicable in Africa and in our societies. Do we need, and that's the same question Nature from Hargeysa is asking, if we have to have a context-based, culturally sensitive strategy for few points, and then I will come back and answer the question. I say Ahmed Ismail.
Yeah. All right. Thank you, Chama, for summarizing the questions. And I would like to go back on some of the items that I would have liked to discuss, but I think answering these questions will help me do that. So I won't take any more time going back to my prepared statement that I shortened because we knew that Professor Fesea was leaving. The main way of defeating this virus is to make sure that we mitigate against its transmission. And the way we do that, we all know now. We all know that social distance works. We also know that covering face and nose also works. Those are the two main ways of defeating this virus. When it comes to mitigation in social distance, that's the challenge that we face in Africa. And in Somaliland and Somalia and Ethiopia and Djibouti and all these culturally similar areas, our people live in multi-generational housing. It's extremely difficult to keep distance when you are bringing people indoors into the same household. So we have to do a smart strategy of doing social distancing. And the other item that we're quite aware now, the finding through experience in the West especially, is that the infection, the transmission of this virus is highest indoors and not outdoors. So we have to also take that into consideration, having multi-dwellings where there are multiple people in the same household where you cannot keep distances easily. The fact that the transmission actually is higher, both in China and in the US. We know in New York, for example, most of the infections were taking place indoors after the lockdown. So we have to also take that into consideration. And the other item we have to take into consideration is, as Dr. Fasiha also mentioned, is that we cannot destroy our people. We're fragile economically. Our people earn their living by working outside. And unless for our mitigation, we cannot completely close that down. So we have to make sure that we let space for commerce to continue, for people to earn a living, and at the same time, try and figure out a way of respecting social distance, having people wear masks, giving them the right information. We all know that the information that we're getting, and this was one of the questions that was asked, we're getting a lot of bad information. We're competing, the health workers, the scientists, the commissions are all competing against false information coming sometimes from the community itself, sometimes coming from religious leaders, sometimes coming from outside. Nowadays, our young people are quite connected to what's going on in the world. They use the social media quite well. And in the social media, there are so much false information. And unless people are very careful of how they read that information, we can also have difficulties. There are stories going around everywhere now. So we have to make sure that we get ahead of that we are proactive, we tell people the right information as quickly as possible. Do we have a strategy? Does Somalia have a strategy? Yes, we do have a strategy. The Ministry of Health and Development has its own strategy. There's an emergency response team that meets every day. They discuss the guidelines, they discuss the tracing. Suhail is right. I cannot say that everything is going smoothly. It's not. We have issues with contact tracing. We haven't learned this before. We don't have the wherewithal, the means, the way of training these young people to go out and trace. And it's extremely important that we do that. We need to have an army of young people going out, doing contact tracing, because the only way you can defeat this virus is to test, isolate, and trace people. One of the issues we have in Somaliland is shortage of testing. We're only now testing people who suspect that they have the virus and come to the hospital for testing, and people who we know are contacts of people who have been confirmed positive. And the issue we have, and I think Dr. Fasiha also mentioned this, is even if you test and people are turning up positive, unless you have a way of isolating those people who become positive from the rest of the population, then you really haven't done anything. So right now we don't have that. Our ability to isolate positive patients whether they are symptomatic or asymptomatic, we really don't have space for them. The only way we do now is trying to figure out a way of isolating them in their homes when they are not symptomatic, when they are asymptomatic, and taking them to the treatment centers. And we have only one in Hargeysa, for example, the center that we have, and that cannot take everybody. So we have to take only the serious cases. Otherwise, it'll be full very quickly. So we are quite inadequate in our ability to isolate and our ability to test. Both of those are lacking. So the question that the point that Dr. Mother has raised about increasing the testing capacity, using, for example, some of the equipment that's already available in Somaliland. And Abdurrahman rightly mentioned that we have a number of Chief Expert machines all around Somaliland. I think we have 14 now. And those machines can be retrofitted. The manufacturer had retrofitted those machines, upgraded them, so they can be also used for coronavirus. They can be used for the SARS-CoV-2. And so we're also looking into that. We're looking into acquiring new cartridges and the new upgrade system for those machines that we already have. In addition to that, I think in the near future, we will have about 5 to 6 PCRs. And those PCRs would then become very useful. And the other point that the other way we can also increase our testing capacity is regionally. We can cooperate between the regions. There are areas in our region, countries in our region that have excess capacity when it comes to testing, and there are countries that, like Somaliland, that are really lacking, and in Somalia as well, lacking in the testing capacity. So we can cooperate. The point that Professor Fasiha raised about interborder, cross-border transmission of the virus is extremely important for us in the region. The border between Somaliland and Ethiopia is quite porous. The border between Somaliland and Somalia is quite porous. Djibouti is the same. So we really cannot, even if we mitigate in individual countries, if we have good testing in individual countries, that cross-border transmission is all extremely important. So what we need to do now is to think regionally and see if we can cooperate in how we also test, so that we don't really need to quarantine people in each country. We can pre-test people who are traveling from Djibouti, for example. Djibouti can test those patients, those people traveling from Djibouti, so that when they come here, we don't really have to quarantine them because they will already be negative. If we do it in the right way, we can do that, and so we would limit the cost and the effort of quarantining that. We could do the same thing in Ethiopia. Also, we could take the samples that we have. Sometimes when we're getting better now. We're getting better now in Somaliland. We have now, we can do almost 200 tests a day. That's still not enough. But we're getting better. We'll get more machines. We'll get even better. But even when we do that, we will still need to have a higher capacity to test more and more and more people. And of course, what we need to do, not just the real-time PCR positivity, but we also need to do surveillance. So we need to do zero prevalence studies. So when antibodies, when correct, specific, accurate antibody testing comes available, we need to jump on that and get ahead and make sure that we know what the penetration of this virus is in our community. That's one of the reasons that I was suggesting that we get more specific data from those countries that are doing testing now, like Djibouti, like South Africa. Those countries, I think we need to get more specific data, breakdown of their data to see what the prevalence is. I was looking at the numbers now, and if you look at both South Africa and Djibouti and Ethiopia, even though Ethiopia is not really doing a lot of testing, the numbers we get, the numbers we get are quite favorable in terms of recovery from the virus. and also in terms of the number of people that have already been exposed to the virus. And that would be important in the future. If there's ever a herd immunity that this virus, we will develop towards this virus, that's going to be extremely important in the future. My feeling is that this virus is going to stay with us for a number of years, not just this winter as I'm worried about, but also next year. Vaccines will come on board at some time. This virus is fortunately quite stable in the important areas. It's a very stable virus. If they spike in that S region, it is quite stable, and that's where most of the vaccines will be targeting. So we will get a vaccine at some point, but it's not going to be before this winter, and it's not going to be early next year. I think it's going to be sometime in 2021. But even if it does, even if we do get a vaccine, we probably will be the last in line for getting this vaccine. We'll be at the end of the queue for getting this vaccine. So the only thing we have now that's going for us is we have a young population that's helping us quite well. Dr. Mother was talking about the fact that this virus kills everyone. Yes, it kills everyone, although the number of people that have passed away, unfortunately, in Somaliland is still small. We do have at least one young person who have died with coronavirus, but most of the patients that have died so far have been aged people, and especially aged people with comorbidities. The numbers are very small, so we can't really tell much about it. But so far, what we see is that the people who are dying, who have died from this virus in our country, are those people who have really already serious comorbidities. So we're pretty much like everybody else. So what we need to do really is in West Africa, for example, one of the advantages that West Africa had was the Ebola experience. And as Dr. Meres was saying, we can use this pandemic and the experience we're getting from this pandemic to improve our healthcare system in general. So because we can see now what we have. So we need to improve our healthcare system because of the problems that we see now. The problems with oxygen, for example. Last week, we had 27 patients in the hospital. And one of the hallmarks of this virus is that these patients need oxygen. They need oxygen, quite a bit of oxygen. And we struggled. We really struggled. Fortunately, no one, because our healthcare, really the people who were at the hospital, nurses, doctors, the other staff, they really pulled together. Even when in the middle of the night, we couldn't really go and get the money for them to get the oxygen cylinders, they pooled their own money together and bought oxygen cylinders for the patients. There are only about 40 cylinders now in Somaliland, and that's not enough. That's really awful. And for that reason, we have, the Ministry of Health has ordered 300 cylinders already, and Dr. Mother and his group, thankfully, and we thank them as well, added 100 more cylinders. Those already left yesterday, Dubai yesterday, and I hope in the next 5 days, 7 days, we will have 400 cylinders now. We have the capacity to fill them. We can fill them, but we didn't have the cylinders. So in a week's time, I hope no one in Somaliland will die because we did not have oxygen for them. We will have them, and we will have the machines running as well. We'll have 3 machines running as well. So what we're doing now is really benefit from the challenge of this pandemic to improve what we have, as Mother said, and we need to now improve our ICU capacity. We really don't have that much ICU capacity. The faulted ventilators are not going to be very useful to us. I think Dr. Mother and Dr. Sayal will agree with me on that. They were not that useful in reality, even in the more modern world. So we're trying to figure out a way of using the ventilators in a different way, as non-invasive. We're trying to now figure out how to use the ventilators that we have as non-invasive ventilators. So it'll be easier for us to use, and it'll be easier for our patients. So we're doing a lot of improvements as well. I think what we need to be thinking about is to make sure that we are not losing time. Time is not on our side. We need to work hard. We need to get our ducks in order. We need to get our agencies all working together. The major difficulty we have now is contact tracing and isolation facilities. Not treatment facilities, but isolation facilities for those who are positive. And those two are the challenge that we have.
Thank you, Dr. Ahmed. I would suggest that since really we have a long list of questions, and our time is really limited. I will be going to ask quick questions for Dr. Abdurrahman Madar and for Dr. Suhai, but also anticipate other questions for Dr. Ahmed Hussein. So I suggest that everyone takes note of the questions so we don't lose time. One of the questions coming from Roble Mohammed, and this is for, I would say, Dr. Abdurrahman Madar can answer, is what we can learn from this pandemic, and especially in Somaliland, but in a wider context in Africa, what we can learn. What we can learn. That is also and what's doctor doing? So I would combine these two questions for Dr. Mada, if he can quickly answer, and then we will pass to Dr. Suhai.
Thank you, Mr. Roble. And I would start with what we can learn. I think there is no shortage of lessons to be learned. It is a disease that kills many people. To come to your question, what we can learn that the prevention. I'll tell you one example. In Western world where I am now, the people usually around patients with COVID are asymptomatic. They stay home. You don't even know there are 6 of them. 20% goes to the hospitals. Out of that 20%, 15% of them only oxygen is enough. The 5% need is ICU, and that is where the mortality comes in. Ahmed Isa was right. Mortality is more prominent in that elderly population. What we can learn is the health system is strengthening. That is key. I'll give you one example. The 2 European countries that we know, Germany and Italy, they are side by side. You can look and search any search engine. Mortality in Germany is probably many times smaller than the Italian one. Germany had a strong health system. They acted early. They even mobilized teams that would go to people's houses and screen and surveillance. And if someone is kind of early sickness, they will preemptively help him out. So what we can learn is work hard to have a health system strength. We learn that our way of life, which is communal, is not helping any disease. So we have to change some of these, as I mentioned earlier. And I think the last one is what the African doctors are doing. I think that African doctor is supposed to be doing, I'm not sure because I'm not there now, but what they're supposed to be doing is mainly prevention, isolation, identification, isolation, and contact tracing. And when they come to the hospital, I would just support plenty of oxygen, as 50% of, now it will be probably 80% of every patient who comes to the hospital, we just need an oxygen. We don't have big ICU. So I would say make oxygen available, prevention, and one important thing that I would like to emphasize is training how to use the Pareil protective equipment. That's extremely important. If you infect and contaminate your mask, your little mask, even this one, even shield, these things that I use, if you touch this one, it can be vehicle. So extremely important to teach the people how to use masks. I see sometimes in the media, people speaking, has a mask, touching the mask. So important basic things, use the little bit that you have appropriately so that they can become a weapon, deadly weapon. If you infect them, you can infect more people.
Thank you, Dr. Mada. The host is informing me that we don't have much time, so I'm going to Dr. Suhail. There is a question from Awo Aden. How to treat immune-compromised pregnant women for COVID? So if we can pay a little bit on the specifically pregnant women and in this case and coronavirus. The second question is for Mubarak, still for Dr. Suhail, and it's asking if hydroxychloroquine and ibuprofen treatment, which has created huge heated discussion, if it can be used or not, and what that discussion ended up at the end. And the last question is still from Mubarak and for Dr. Suhail, is whether the virus is losing the potency, so that it's becoming weaker. Those three questions, if you can summarize quickly, please.
Thanks to all the participants who's asking us the questions. I will go directly to the immune-compromised pregnant woman. We have to say that whether you are pregnant or non-pregnant, you have to get the appropriate treatment when you come to the hospital. Particularly if the person is pregnant, you know that you have two lives, the fetus and then you have the mom. So you have to be careful when you're treating both of them. So what they need actually when they come to the hospital, so it depends on what kind of disease they have. What immunocompromised disease they have. Is it HIV? It's tuberculosis? Is it diabetes? Is it cancerous? It depends on the disease that the pregnant woman is suffering from. So we have actually to be careful when we're treating pregnant women, and we have to be a multidisciplinary. So we have to call obstetric doctor so as to deal with the fetus and the mother at that time. And then we have to call those are the emergency, and those who are dealing with the COVID-19 has been trained how to treat this issue. So it depends on what she needs at that time. Is it oxygen? Is it fluid? Is it a relief of fever? And then you treat those depending on what she presented with. And that's how you be careful with the immunocompromised pregnant women. If I come to the other question, which is the virus losing the potency, I will say we didn't hear that from WHO yet, because we know that WHO, this virus is novel. Novel, it means is new. We're still learning a lot of things. Every day we have a new thing that's coming. It's too early to say that the virus is losing the potency, because still we are seeing that it's killing people. The virus is killing a lot of people. So we cannot say that it's losing its potency. I have forget another one question. The other one was what?
The discussion that taking place about the treatment.
Okay, about the treatment. Okay, there's a big discussion. WHO has a big discussion about that treatment of anti-malaria. They are very against that treatment. Actually, they're saying there is no evidence that this treatment is helping COVID-19 patients. Either they're saying it's causing a lot of problems. So we cannot say now this treatment is helping COVID-19 patients. It is too early, or WHO didn't recommend it during this pandemic.
Thank you so much, Dr. Suhail. Now I'm going back to Dr. Ahmed Hussein Isa, and I have really, I apologize if I couldn't pick all the questions, because there is a long list of questions. And the first one is from Alale, who is asking specifically, Dr. Ahmed, if in Somaliland and in the region, if we reached the peak, otherwise, if not, don't we are celebrating too early now? So that's a question specifically to see where we stand with the peak of the virus transmission. The second question is from Professor Giorgio Banti from Italy, who's focusing on the economic aspect, and he says that economic consequences of the lockdown and the other measures of the contrasting of the spread of this epidemic are looming lagging in European countries. And he mentions how jobs are lost, shops are closed, most of the entertainment and free time industry stopped, and so on and so on. This creates a huge crisis, and social and economical, I would add. About African countries, we read and heard about health issues, but very little about what governments are planning to do in order to address this social issue. If Dr. Ahmed can say a bit about that. Now I will leave you for these questions, which are extremely fundamental from the aspect of social, economic, and then we will come for the last round of questions. Dr. Ahmed.
Yeah, thank you, Dr. Chama, and for Alale and other participants for asking the questions. I'd like first to go back to the question about the potency of the virus. Is this virus losing its potency? And I agree with Suhair. We don't have to rely only to the WHO, but I think all the evidence that we have is that this virus is still the same. There are no strains that are coming out that we know of. It's still the same virus. It's still as potent, and it's likely to be that way. Viruses sometimes do lose potency as time goes on, but this virus we don't know much about, and so far we don't see any difference between the potency of the original infections and the ones that are now quite common. It seems to be the same everywhere. The question about hydroxychloroquine and ibuprofen was also included in that. I think the consensus now is that this medicine is sometimes used not for the sake of the malaria, but it's sometimes used for other connective tissue disorders to lower the immune reaction against some parts of the body. And that was the idea behind it, because there's a question that some of the damage that's done by the virus, especially in the lungs, comes from what's termed as a cytokine storm. So if you diminish that, then maybe it would be helpful. So it was used in that way, but so far we haven't found any evidence that it works. We have found that it actually could be counterproductive because it does induce some very difficult cardiac problems. So nobody's using that now in the main hospitals. But of course, you cannot stop any doctor because it's a medicine that's available, that has been used for a long time. So any doctor can still prescribes it for his patient, but it's not part. It has been taken out of the protocols that are now being used internationally. Did we reach the peak? No, we have not even started. We have not even started with this virus. We have not even, the exponential phase of the virus, the exponential growth of the infections, we are not seeing yet. We're seeing local transmission, low-grade local transmission throughout Somaliland, but not an exponential growth and not a peak. So we really have to be very careful in what we do now to forestall that getting into that exponential phase. We've been lucky so far, but as in my previous statements, we have been so far. The economic and social issues, I think we'll be discussing those in the future. If we're not careful, we can destroy in how we mitigate, in how many hours we allow people to work outside the home, make sure that people who are losing their income, destroying the livelihood of our own people. But we cannot do that by handouts. We have to do by doing smart mitigation that allows us to limit the spread of the virus, and at the same time allow for an economic activity. Many places well. So things are coming up now, as I think as we limit the infection in the world, that we also our testing capacity at the borders, our testing capacity at the airports, within the community is robust enough that we can identify the cases very quickly, so we can allow our people to live as normal, as a new normal life as possible. But at the same time, make sure that we are not being hit by this virus, and we're not getting into an exponential growth very quickly. I think the problems of this virus are still ahead of us.
Thank you so much. We have 5 minutes, and we will try to come to answer as many questions as possible. Siak Obachi is asking few questions, and one of them I will pick one of those, and this is for Dr. Abdulrahman Mada. What about the use of herbal cures, and what, for example, in Madagascar president has suggested? What we can say about that?
I will be very quick. One thing I agree with him, that every medication that we have mainly has some roots to herbal medications, but the way the science and the medicine has been for the last hundreds of years, we use new medication or new herbal when you test safety and efficacy. So I'm not familiar how processes this herbal medication went through in order to test efficacy and safety. So I can't answer that. So I will leave that to probably you, Chama.
Thank you so much. I'm passing to Dr. Suhail. With Mr. Kennedy from Hargeysa is asking, by the way, we have only 54 out of 376 people recovery. That means low as 14%. So he says, where is the problem? I would like to answer, but I leave you panelists to this.
It could be that we know that those who've been recovered at those that he provided, that 14%, and then again we have around 20 people who passed away. So maybe those cases are still positive. They didn't become recovered, or they didn't pass to the other. They didn't even pass it away. So we have them even. They are test positive yet. So we cannot yet say what's wrong, because unless we see the outcome, now we have the cases, and then we have a different outcomes. You either cure or recover from the disease, or you pass it away. So there is nothing between the two, pass it away or cure it. So it means that still they are positive, and positive, it means we don't know for how long they are positive. It depends on the duration. But maybe Dr. Ahmed can explain a bit more about it, since he's part of the COVID responders.
Okay, I will pass that question to Ahmed, but I want to add while someone is unmuting Ahmed. Yes, I will pass that question, but before he answers, I want to add also another from Khadar Farahai, saying the world is focusing on using technology and applying the high tech for tracing and for documenting. does Somaliland use any kind of technology, high technology, or way to trace out for the tracing? Before I give Ahmed, who will conclude, because we are running actually out of time, and he will conclude our discussion, I want to go back a little bit with Kennedy's comment of what's problem. We have a serious problem. We don't want to underestimate the virus and this coronavirus and this disease is really deadly. So we have a problem. As all of the world, we have a problem. So we cannot underestimate and say what is the problem if only few people are hospitalized. Mind you that we don't have the testing capacity. So if we were able to test only 376, imagine how many people we couldn't do that. We couldn't do the mass testing. So probably we could have more numbers if we use statistically the numbers. So I will leave for Dr. Ahmed to conclude the discussion as well with those two questions.
Thank you. I think the question about recovery is certainly important, and I think Suhair answered that question correctly. In COVID, recovery lags because of the way the virus, the way people recover from the virus. It takes a while, and as you enter new patients through testing into the numbers, the number of people that have recovered adds up to those people who are already in there, who are already in the process of recovery. And we're not letting people out until they test positive, negative for the virus. So we cannot call them recovery until we make sure. And if you look in this case of Somaliland, testing, the proper testing just started about 3 weeks ago. So we've been enrolling patients into the system, and it's not time for all of them to recover. Even those people who are quite healthy now, who are even maybe only slightly symptomatic, who can be released from even the hospital because of the lack of symptoms and the lack of fever over 48 hours. They still wait for the proper testing now. So it's lagging behind, but the 14% is reflective of that. If you look at other countries, in Africa, where testing has been going on for a while, it's quite favorable to European and American situation. We're getting about 43% recovery at each time. So right now, after a period of testing, Africa is about 43%. The US is about 30% recovery, and more cases are being added all the time. That's a problem. And Europe is about 50% recovery because they were early. Technology is extremely important, and Somaliland is fortunate to have young people that are quite tuned and capable of creating apps. And we have, in our own university, we have created an app and a website that does that can track everyone, like the Chinese do, that can track positive patients, tested patients. We can track those. So we will be going towards that as we go through this pandemic. I think using mobile technology, the new technology, will be useful in Somaliland, and probably earlier in Somaliland than in many other countries.
We are going to close and one last, really 1 minute question and answer to Dr. Ahmed Khadarsham, I think from Italy, is asking if we ever did any kind of research on Kududia that happened in Pareil as per experience and to be useful for the coronavirus.
The Kududia, okay. Yeah, of course, there was some of the misinformations that we get sample is about that chikungunya virus that we call Kududia. Many people are saying, well, we went through that, the Kududia, it affected Djibouti, it affected Ethiopia, It affected Buro quite harshly, and we survived. And this is just a kururia, really. That's what people are saying. We haven't really, we haven't used any experience from kururia to COVID because they're completely different viruses and different factors. The way you catch the respiratory virus, the kururia is vector-borne, so it's quite different. But to the people with negative plays on COVID, because people are saying, we recovered from the kururia, that was a piece, so this is nothing to us. Some people are confusing the two. So that experience has not been in this, mainly because we haven't really spoken about that kururia. We haven't really, we haven't done the right research on the chikungunya virus in Buro and Hargeysa and other places. We haven't done that. That's what we should have done because now we could have answered some of those questions. But we haven't done any research that I know of. Maybe other people know about some things that have been done, but no, we haven't done anything with kururia, and we're not applying, except in a negative sense, the experience that we had with the kururia.
Now I'm really going to close. I will pass to Tirsi to just say two things about the next upcoming events. But before I do that, I want to really thank my guests. It was really a pleasure to have you here, and the discussion was helpful. I see that Yasin Hassan from Hargeysa really asked a long list of questions and timely questions. But we will be definitely discussing those questions in the next webinars, because there are specific webinars dedicated of the questions that Yasin Hassan asked and others. So one more time, I really want to thank those people who are asking and engaging and asking questions, both via Facebook and also comments on Zoom. Tirsit?
Thank you very much, Doctor. And the 2 points, one of the points you already have addressed it. I really want to say thank you for everyone, mainly for our panelists. Even though Professor Knight is not with us now, but definitely she will be able to get the message out through this, because we have had a lot of questions and comments coming to her. Thank you very much, everyone. The speaker, Dr. Ahmed, the respondent, Dr. Abrahman, and Dr. Suhair, and Dr. Jama, yourself, for putting such an interesting question and engagement. The other point in the attendance, Dr. Jama and Dr. Ahmed also said, we have upcoming 12 episodes. This is the first episode, and we have had a lot of inspiring comments, questions, ideas, which I am pretty much sure they're going to be covered in the upcoming episodes too. And also we will be engaging on social media, addressing and providing relevant information we got from this conversation. Just to give you a hint of what's coming next, our second episode will be covering mobility, migration, and movement in the African context in general. And as usual, we'll be focusing on the Horn of Africa too. So I'll be sending out the webinar invitation, and I hope everybody will be accepting, and then we'll be having a much more effective connections. Thank you very much, Doctor.
Do we know the next speakers for the next session?
Yes, definitely. And thank you very much again, Doctor. So the main speakers for the next episode will be Dr. Laura Hamid from SOAS University, who has been who is still and who has been working on migration and related issues in the whole Africa, which is specifically focusing on the Horn of Africa region. And also we have Dr. Mahari from Addis Ababa, and he also is currently working with IGAD, and he has a lot of experience in the migration and related issues. So these are the main speakers, and we also have respondents coming from Migration Research Institute in Jigjiga University and a scholar from Somaliland. So this will be the bits that we have, but we also will include discussants as participants and also respondents. So thank you very much once again, everyone, for joining us, and I definitely will hope to see you all in the next episode.
Thank you.
Thank you very much.
Thank you very much. Bye-bye.
Bye-bye.
والله يا صالح